If you're enjoying this Med Prep to Go Step 1 podcast, you can now get the content along with the content of the Crush Step 1 podcast ad-free in one bundle. Just go to medprep2go.com and find our new subscription podcast called Med Prep to Go Step 1 Bundle.
When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite, obey your thirst.
This episode is brought to you by Indeed. You're ready to move your business forward, but first you need to find the right team. Start your search with Indeed Sponsored Jobs. It can help you reach qualified candidates fast, ensuring your listing is the first one they see. According to Indeed data, sponsored jobs are 90% more likely to report a hire than non-sponsored jobs. See the results for yourself. Get a $75 sponsored job credit at Indeed.com/podcast. Terms and conditions apply.
Every who down in Who Newville liked the holidays a ton, but where to get great prices on gifts they had no idea. None. They searched and they searched for great gifts under $25. Gifts for spouses and friends and even their toddlers. When suddenly one who shouted, Walmart has what you want, knowing they have Lego, Tree Hut, and low prices to flaunt. So they enjoy the holiday season as Who's often do. Cheering and shouting, Walmart has incredible gifts. Who knew? Find gifts they'll love under $25 at Walmart.
Hi, I'm Dr. Raj, and this is the Med Prep to Go podcast. I'll be reviewing USMLE Step 1 questions. In fact, I'll be reviewing 3 questions today from everyone's favorite topic, and that's going to be pathology. So to get more questions, go to our website, www.medprep2go.com. This is the free audio and online question bank. And to learn more about me, Dr. Raj, check out my own podcast, the Dr. Raj podcast. I also have my other one called Beyond the Pearls podcast. It's really keyed up to my 2-book series. One is called Morning Report Beyond the Pearls for Step 2 and 3, as well as my case reports Beyond the Pearls, really geared towards Step 1. And, I love it. I love it when you follow me on social media, Instagram, Twitter, Facebook. And you know what? I hate to admit it. I think I do some TikTok stuff. It's kind of embarrassing, but you can check me out there too. So let's get to these 3 pathology questions. We have a 17-year-old girl presents to the emergency department with excruciating retrosternal chest pain. She reports that the chest pain began abruptly less than 2 hours ago. There was no preceding trauma. Her past medical history is significant for bulimia nervosa. And that stinks. Any of these disorders where you're binging and purging, they're just horrible. Many individuals, both men and women, suffer from these. And any type of eating disorder, I just always feel bad about. And when we talk about, I'm just going to do a side pearl right here. If someone comes in and they have bulimia nervosa, did you expect them to have a metabolic acidosis or a metabolic alkalosis? What do you folks think? I just want to skew. The answer is, yeah, you kind of think they're going to have metabolic alkalosis. Why do you think that? It's because they have all this vomiting. And when you have all this vomiting, oh boy, you're definitely predisposed to getting a metabolic alkalosis there. So just on a side note, okay? Remember when you get lots and lots and lots of diarrhea, what do you expect? You'd expect a non-anion gap metabolic acidosis, vomiting, metabolic alkalosis. So her history is significant for bulimia nervosa, but otherwise is unremarkable. She denies tobacco, alcohol, and drug use. Vital signs reveal some tachycardia and hypotension. Which of the following would be most likely in this patient? A, chest wall crepitus on physical exam. It's kind of like feeling for the Rice Krispies when you're doing palpitation of the chest wall. B, elevated troponin. That sounds kind of like a lame answer. Why? Do you folks think that this 17-year-old girl is presenting with a myocardial infarction? Highly doubt it. I know it said chest pain, but common things are common. I'm not suspecting an MI. So I'm not going to pick B. C, increased gastric acidity. Don't get me wrong. She's, vomiting and purging and all those things, unfortunately. But to say that the big thing is that she's having really bad heartburn that abruptly started 2 hours ago, that really doesn't make a lot of sense, especially excruciating chest pain from some heartburn. I don't know. I don't buy it. So I'm not going to go with C. D, infiltrates on chest x-ray. So you're saying she has some kind of pneumonia. Maybe she aspirated or something like that. But abrupt onset 2 hours ago, excruciating. I mean, that's some powerful pneumonia, I'm not going to go with that. E, ST segment elevation, kind of going along with B, thinking that this is an acute coronary syndrome. And, raise your hand. Does anyone think a 17-year-old woman with the history presented here, which is just edema nervosa, is going to develop an acute coronary syndrome? I didn't think so. So you're kind of backed into saying what? Chest wall crepitus on physical exam. And that is the correct answer, which is A. And I see where they're going here, and someone is vomiting. Suddenly you get a what? Tear of the esophagus, and it's time to memorize. Who knows what syndrome that's called? Yeah, that's going to be a Boerhaave syndrome. And when we talk about the right answer here, Boerhaave syndrome, forceful vomiting can lead to esophageal rupture, secondary to increased intraesophageal pressure. In Boerhaave syndrome, physical exam may be significant for chest wall crepitation due to subcutaneous emphysema. Boerhaave syndrome leads to mediastinitis that can be actually very, very dangerous and be an infected mediastinitis due to contamination of the mediastinal cavities with gastric content. That's horrible. And when you shoot a chest x-ray on these folks, I know the answer was D, not the answer, but choice D said pulmonary infiltrates on chest x-ray, but you could see something called pneumomediastinum. You got air on that subcutaneous space. That would be the chest x-ray finding to think about. No, the right answer here is definitely A, that chest wall crepitation. On imaging of the chest, you would see pneumomediastinum. Choice B, elevated troponins, is incorrect. There's no risk factors of coronary artery disease. Choice C, increased gastric acidity, is incorrect. I agree. This patient does have self-induced vomiting and other purging. Increased gastric acidity results from things like gastritis, esophagitis, GERD, gastroesophageal reflux disease. But this clinical vignette of sudden onset of excruciating chest pain does not correlate with that diagnosis of increased gastric acidity. Choice D, pulmonary infiltrates on chest x-ray. We talked about it already. I could believe that she could have aspirated, and maybe we'll see findings in maybe the right lower lobe. Doesn't necessarily have to be a bacterial pneumonia. It could be kind of like a inflammatory where you could have aspiration pneumonitis, but I just don't think that this is going to be the way they presented it with the excruciating chest pain, that's going to be the answer. They were implying pneumonia in this case. And choice E, the ST segment elevations. Don't get me wrong. In most cases, someone screams chest pain in the emergency department, you are going to get an ECG, but I really highly doubt that this patient is going to have an ST elevation MI. So what's the key learning points here? Chest wall crepitus due to subcutaneous emphysema may be seen in patients with Boerhaave syndrome. Other clinical manifestations include mediastinal crackling with each heartbeat due to mediastinal emphysema, chordal auscultation. You can get fevers, tachypnea, tachycardia, and hypotension that can be multifactorial. Great question over here. Let's do another. We have a 58-year-old man presents in the emergency department with shortness of breath, chest pain that worsens on inspiration. So kind of like a pleuritic chest pain, and diaphoresis for 3 hours. So really acute. Past medical history is significant for hypertension. And poor guy, he's got gout. He works as a truck driver, meaning that he's going to be a sedentary, sitting in the car for extended periods of time. I wonder where they're going with this. Acute onset of chest pain, pleuritic in nature, and I drive a truck. Okay, we'll see. Vital signs are afebrile, 98.6, BP is 130/100, heart rate of 109, respirations are 22, so a little tachypnic, and they do an arterial blood gas. All right, hope they didn't do that before a chest x-ray, because I don't think I'd be doing ABG right off the bat. And the pH is elevated at 7.6, PCO2 of 28. So just based upon those, looks like they're a respiratory what? Alkalosis, very good. But let's just confirm it. The bicarb is at the numbers, 24, it's normal. PaO2 is 68, so it's on the lower side. But they didn't give us the O2 sat, but with a PaO2 of 68, it's a little bit on the lower side. The O2 sat probably still in the 90s somewhere. And how do I know that? Going back to U assembly, step one, physiology. the oxygen dissociation curve. Remember that you're going to have on the y-axis your O2 sat, on the x-axis your P(a)O2, known as your dissolved oxygen. And yeah, I mean, your PaO2 could drop down pretty significantly, and you're still going to be at that high 90 plus saturation percent. So choice A is going to be, an acute PE, pulmonary embolism. That will definitely be high on my differential. B, atypical pneumonia. And I guess when you think of atypical pneumonias, we don't really use that terminology as much anymore. I think historically, radiographically, you say typical pneumonia, think of a lobar consolidation. And of course, the number one culprit is always going to be strep pneumo. When you say atypical pneumonia, I'm sure someone's going to yell out Legionnaires. Someone's going to yell out walking pneumonia, which is mycoplasma. Someone's going to say chlamydia. So this is all correct, you know what I mean? But remember that there's no guarantee that Legionella will always present with a bilateral infiltrative process. It could be lobar sometimes, you know what I mean? But you're thinking of atypicals here. I think mycoplasma and Legionella behind the differential, but this doesn't really present with this acute onset, 3 hours pleuritic in nature. Don't get me wrong. I mean, pneumonia will definitely give you pleuritic chest pain, but patient's also afebrile. I'm just throwing it out there. C, I don't know where they're going with this. Ethylene glycol poisoning. I don't know if they feel that the truck driver needed to be intoxicated and couldn't find any regular alcohol. But if you're going to throw that out there, dude, hook me up with a what? Give me some metabolic acidosis. Give me the gap. Hook me up for some gap. Give me an osmolar gap. So I don't know where this is going from, unless they say he has a craving for antifreeze. I was just trying to be funny, which I'm not. D, obstructive sleep apnea. That makes absolutely no sense as a choice. Sleep apnea doesn't present with acute onset of pleuritic chest pain. E, pseudo-hypoaldosteronism. Well, that just means you don't have aldosterone levels. I don't know why that would happen unless you damage your adrenals, but this is not it. And patient's blood pressure is pretty normal. I'm sure if you don't have any aldosterone, you're going to be a little bit on the hypotensive side. And choice F, wow, the writer went for it. Severe salicylate poisoning, meaning that you took too much aspirin. That would be kind of mean to write, seeing how in the vignette it doesn't mention that the patient has taken aspirin. And I guess if you want to play the acid-base game, what's the memorizing thing for step 1? Patient will have a metabolic NI-gap acidosis, and will also have a respiratory alkalosis. So maybe the writer was like, hey, I like to be tricky and put a respiratory alkalosis like he did in the question, but then you had to give me all the goodies. You got to give me the sodiums, you got to give me the chloride and bicarb, because I need to calculate the NI and gap. And also I need to figure out, is there going to be, another disorder there, which we didn't do. So, if I was bullied into something, I would pick what? A is an apple. Definitely this is a PE. And guess what the right choice is? Yay, it's a pulmonary embolism. And these patients often develop what we call dead space physiology. What is dead space? When you have a clot in the vasculature, but the alveoli, where the ventilation goes from, is beautiful. So in theory, pulmonary embolism is classically dead space-like physiology. When you have like a PE, I'm not talking about a massive PE causing syncope or hypotension. I mean, most people with a PE, you kind of hyperventilate because you got a PE. So classically, we do see a mild respiratory alkalosis. And they do tend to be somewhat hypoxic. And they also develop a widening of the AA gradient. So this is kind of where they're going with this arterial blood gas. Choice B is the wrong answer, like we already talked about. Infections are really not going to present as an acute onset. We talked about mycoplasma. We talked about Legionella, chlamydia, pneumonia. And also, of course, in this question, really the lack of fevers here, the lack of cough here. So really doesn't kind of correlate with that. And it says, chest x-ray, doesn't really show any type of pneumonia. But let me ask you this rare question. Can someone tell me one chest x-ray finding that you may see if you have a pulmonary embolism? You can get what's called a wedge-like infarction, right? Cool, man. And does anyone know the name of that? What do we call that? Why are you folks so smart? You're right. It's called a Hampton's hum. So you guys are ready for the boards. Choice C, ethylene glycol poison, is incorrect. We already spoke about that. There's no NI-gap metabolic acidosis. And if I were to ask you what's the antidote for ethylene glycol toxicity, who could just yell out what the antidote is? A little memorizing. Omeprazole. And sometimes if the kidneys are super damaged, dialysis. Choice D, this is not obstructive sleep apnea. Most people, though, say do not present with a respiratory acidosis. There is another entity called obesity hypoventilation syndrome. They do present with a respiratory acidosis that's more chronic in nature, and that will be present both at night and during the day. Choice E, pseudo hypoaldosteronism, is not the right answer. These individuals, if you don't have aldosterone, tend to be on the lower sodium side, tend to be hyperkalemic, tend to have a metabolic acidosis, which this patient did not have. And the blood pressure was good. And last, severe salicylate poisoning is incorrect based on the vignette. And we talked about some of the acid-based findings. Usually you have a anti-gut metabolic acidosis combined with a respiratory alkalosis. Limiting point here is that in most people with a mild, small, not too big pulmonary embolism, they could present with a respiratory alkalosis, hypoxemia, widening of the A gradient. All right. Wow, I really kind of went to town with that one. Sorry about that. Sometimes I get a little sidetracked when I enjoy the question. Last one's pretty quick. Let's talk about this 35-year-old woman presents to the emergency department with complaints of intense right-sided flank pain, nausea, vomiting for 6 hours. So once again, kind of acute. Plain films of the abdomen reveals opaque stones that look like antlers obstructing her entire renal pelvis. Wow. Laboratory testing reveals a normal serum creatinine and a urine pH of 11. Wow. That's impressive. Which of the following is most likely the chemical composition of these stones? Can you name that stone? You know what? That would be a great show. Name that stone. Is it A, calcium oxalate, B, cysteine, C, magnesium ammonium phosphate, or D, uric acid? The correct answer here is C, magnesium ammonium phosphate. So another name for these stones are called struvite stones, which are high yield for the boards. They are strongly associated with urinary tract infections with organisms that split urea with their urease enzyme. This results in a highly alkaline urine, hence pH of 11. That's super alkalemic. A key finding associated with magnesium ammonium phosphate stones is what I mentioned, that high alkaline urine. These stones may grow rapidly over weeks to months and may get so large that they fill the entire renal pelvis and are called staghorn colliculus because they look like antlers. These stones appear radiopaque. Choice A, calcium oxalate, is incorrect. Calcium oxalate stones represent the majority of kidney stones, which I totally agree with. The risk of calcium oxalate stones formation increases as urine oxalate excretion increases. These stones are radiopaque, but are usually associated with a low calcium diet and increased intestinal calcium absorption with malabsorption syndromes such as inflammatory bowel disease, which really encompasses two things, which is ulcerative colitis and Crohn's. Choice B, cysteine, is incorrect. Cysteine stones are most commonly found in children as a result from the genetic disorder called cystinuria. Answer choice D, uric acid, is incorrect. Uric acid stones are radiolucent. Conditions that increase the risk of uric acid stones include gout. Don't forget that monoarticular inflammatory arthritis. And of course, gout always likes to affect the big toe, especially when we talk about USMLE questions. And if you have gout of the big toe, what do we call that, everyone? Memorizer, podagra. Good job. Also, chronic diarrhea, diabetes, and having the metabolic syndrome also puts you at a higher risk for uric acid stones. So the learning point here is struvite stones are made of magnesium ammonium phosphate and are produced by urea-splitting organisms, resulting in a highly alkaline urine. So those are our questions today. I hope you enjoyed those. And to check out more questions, go to our website, www.medprep2go.com.
Hi, everyone. This is Ted O'Connell. I just want to let you know that we have launched a Step 2 QBank podcast, very similar to our Step 1 QBank podcast. Each episode will have 3 questions so that you can study on the go. We are actively recording these and plan to release a new episode every 2 weeks. We're also launching a premium podcast bundle that will include ad-free access to USMLE Step 2 Secrets podcast, as well as early and ad-free access to all of our episodes from the Step 2 QBank podcast. So please go over to our website at medprep2go.com and check these out, or you can access them wherever you get your podcasts. Thanks so much.